Good morning, good afternoon, good evening. I am Valentin Fuster from Mount Sinai Medical Center in New York, and we are in Philadelphia. Why? You know, the American Heart Association scientific sessions this year are in this beautiful town. Well, as usual, we would like to summarize this meeting, particularly the breaking trials, and we always have experts in the fields, in the different fields here. So I'd like to introduce my colleagues, all well recognized by you, but let me start from my right. Dr. Joshua Beckman, who is Professor of Medicine, Director of Vascular Medicine at the University of Texas Southwestern. He's a really, really good brain on clinical trials. He's in the guideline business, so we have a lot to discuss today. Then we have Dr. Amanda Best, Director of Advanced Heart Failure and Transplantation at the Tufts Medical Center in Boston, and she's a real expert also in nutrition. All right, so then we move into, you're originally from Italy?
Yes, correct.
Okay, so I was right.
Yeah.
So it's Dr. Pasquale Santangeli, who is Director of the BT program in pacing at the Cleveland Clinic. And then we have Roxana Mehran, who I see her every day. She always has things to ask. Professor of Medicine, Director of the Center for Intervention Cardiovascular Research and Clinical Trials at the Mount Sinai Medical Center in New York. Well, first of all, thank you very much for being here. People don't know, but we are just at 6 o'clock in the morning. Thanks for coming at this time. Well, let's go into the program today. This is an interesting meeting, and see what your judgment is. We are going to be discussing 7 different trials. The first will be the SELECT trial on semaglutide. Then we have ARTESIA trial and the AZALEA-TIMI 21 trial, both in atrial fibrillation. Then we have the ORBITA 2 trial on stable angina. And then we have 3 studies related to 3 genetic disorders: Lp(a), heterozygous familial hypercholesterolemia, and then a type of hypertension. And here we are going to be discussing pharmacological approach going to the gene or to the RNA pathway coming from the gene. So this is a very interesting aspect. I think it's a very rapidly evolving aspect in medicine today. Well, let's begin now with the first study. The first study is the SELECT trial. Is semaglutide and cardiovascular outcomes in obesity without diabetes. This was presented by Dr. Michael Linkoff from the Cleveland Clinic. Well, you all know about semaglutide. Let me tell you, this is the subcutaneous injection every week for people who want to lose weight. So let's start from there. Interesting. What about outcomes when we use this drug? We know about weight reduction, but let's now see what happens in patients who are obese and at the same time they are diabetic and they have a high risk for cardiovascular disease. We already know the answer. There is a decrease in cardiovascular events with the use of semaglutide subcutaneously once weekly. But what about people who are obese? They have cardiovascular disease or high risk factor for cardiovascular disease, but no diabetes. Mm-hmm. This in itself is going to decrease cardiovascular mortality because on the first studies already published in diabetes, maybe the decrease in cardiovascular mortality was because the impact on the diabetes. Today, what about the impact on the weight? So it's interesting, and let me now define the study. The study was conducted as a multi-center, double-blind, randomized, placebo-controlled, event-driven superiority trial at 804 clinical sites in 41 countries. So it's a very well-spread trial. So as I mentioned, double-blind, randomized, placebo-controlled, event-driven superiority trial, enrolling patients 45 years of age or older who had pre-existing cardiovascular disease and a body mass index of 27 or greater. So not necessarily all is obesity, but maybe overweight. But these patients, as I mentioned, they don't have any history of diabetes. Patients were randomly assigned at a 1-to-1 ratio to receive once weekly subcutaneous semaglutide at a dose of 2.4 milligrams or placebo. Now, the number of patients, 17,000, were enrolled, half of them into the semaglutide and half of them into the placebo. The follow-up, 34 months. Now, here we have the primary cardiovascular endpoint was a composite of death from cardiovascular causes, non-fatal myocardial infarction, non-fatal stroke, in a time to first event analysis, and the safety was also addressed. Well, let's see the results. First, about the primary endpoint. Primary cardiovascular endpoint, we have 6.5 events in the semaglutide group, percent events, versus 8% events in the placebo group. Again, this is a follow-up of 34 months. And then we have, in terms of adverse events, is interesting because was higher, maybe as expected, in the semaglutide group, 16%, but 8% in the placebo group. But when you go into serious events, it's the opposite. For some reason, the semaglutide group did better. Well, let me now quote the conclusions from the paper that just came out in the New England Journal of Medicine. In patients with pre-existing cardiovascular disease and overweight or obesity, but without diabetes, weekly subcutaneous semaglutide at a dose of 2.0 milligrams was superior to placebo in reducing the incidence of death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke at a mean follow-up of 39 months. Well, I think you are an expert, Amanda. You're an expert in nutrition, isn't it?
That's right.
So tell us what you think. What do you think? By the way, the weight decreased by 10%.
Right.
Anyway, tell us what you think.
Very exciting trial, and it really gets to the heart of this cardiovascular kidney metabolic disease that the AHA has been talking a lot about recently. And I think, in fact, it not being a weight loss trial is even more exciting because here we really see how the attention to metabolism and using the GLP-1 agonist medications can really improve hard cardiovascular endpoints, which is, of course, the most important thing when we're looking at our patients who may have a metabolic disease such as obesity. So a really important step forward for us, I think.
Well, thank you. Roxana, we are getting a lot of experience with semaglutide. And the question is, when you stop the drug, things come back. I'm now talking about weight. I'm not talking about cardiovascular. So it's a challenge, isn't it?
Yeah, I think it's challenging. We're seeing a lot of side effects. Especially GI side effects. I personally have not seen any pancreatitis in my patients, but certainly we saw that some of that has been previously reported. But what I was really struck by is how these events separated so early in the course of the treatment without the weight loss. So there must be some other mechanism that we need to understand.
So Pasquale, frankly, if they give me this drug and said, you know, this is just to decrease cardiovascular mortality because you are obese, I think my reaction would be, I am obese, let me lose weight. I don't think I'm going to look at because cardiovascular mortality is going to decrease. So tell us, what is your feeling about this new approach? Because it's all over the place.
Yeah, but I have to be honest, when I was at the presentation, I was struck by the Kaplan-Meier dividing so early. So it seems like the benefit is so, it outweighs the weight loss, and honestly, the drugs seem to be fairly well tolerated. There were no significant adverse side effect, pancreatitis. There was another study that looked at renal failure, I believe, and there was none of that. So I was surprised by that, and I think it's a step forward.
Well, Joshua, there's something I don't understand. See if you're able to help me on this. Semaglutide, decreasing cardiovascular events. I understand this in diabetes. We are not in diabetes. We are now obesity, weight gain, it says you decrease cardiovascular events, but the weight only decreases by 10%. So tell us what you think, and then I will go to the expert about this issue.
So we know that the rates of cardiovascular events begin to increase as insulin resistance begins to increase. And that begins well before the onset of frank hyperglycemia and diabetes. So I think attacking the insulin resistance portion of the metabolic disarray that comes with obesity is the way that this is likely improving cardiovascular outcomes. I don't find it very surprising. I think by waiting until many of these patients get diabetes, we've already let the horse out of the barn. Better to attack the problem before severe disease and complicating factors that come with diabetes are present.
You know, Amanda, this is a very good answer, actually. We have a study that we did, we look at ultrasound, subclinical disease, and we found that in insulin resistance, even before prediabetes, there is a lot of subclinical disease. So it seems to me that maybe this is the mechanism. What do you think?
Yeah, I think that's very plausible. We know so much more now about the adipose tissue, the gut hormones, and the interplay that they have with our cardiovascular health. A lot of that actually came from bariatric and metabolic surgery, that we began to understand how the sick fat, as it can be called, interacts with cardiovascular health. And I think this is a really exciting time for us to be thinking about the lifestyle medications for metabolic health and weight loss, along the continuum then to pharmacotherapies and then to surgery. And I'd encourage people not to think of them as three silos, but really think of them as very integrated. For one patient during their cardiovascular and metabolic health journey, there may be an opportunity for various number of those therapies over time. And in a response to this question about, well, what happens when the GLP-1 agonist stops? Yes, we do see weight regain. We do see the metabolic health slipping back, but so too when we withdraw a medication that treats hypertension or treats diabetes. And I think here we're just seeing the same for metabolic and obesity.
Pasquale, you are in an interesting specialty, EP. Now, are we going to develop a new specialty in cardiology? Will be cardiometabolic, obesity, and diabetes? It seems to me that the cardiologists were not really into it, how you treat a diabetic patient, obesity, and so forth. So it seems to me now this cardiometabolic is like another EP kind of section. Is not correct?
I agree. This is really something that is building up. And from our field, atrial fibrillation, it may be part of the spectrum of a metabolic disease. And I wonder if this drug may work to reduce AFib in patients that are overweight, and that probably for the future.
Roxana, it doesn't happen to you. This happened to me. All of a sudden, I began to be an expert on the field of obesity and diabetes and so forth. And if I go back to me 5 years ago, I don't think I had a word to say about it.
No, there's no question about it. We all need to be more educated and absolutely educate our patients more. I find myself spending a lot of time with the women in the women's clinic who are asking for these drugs to teach them about the cardiometabolic syndrome. And I think this is very, very important. And I think you don't give yourself credit. I remember when Freedom was presented. This was a revascularization trial of CABG versus PCI in diabetic patients. And when you presented it, the only thing you wanted us to pay attention to was not the outcomes of PCI versus CABG, but the lack of our ability to get to goal in diabetic patients in terms of their cardiometabolic health. And I think that's a chronic issue.
This is interesting. Actually, I talked yesterday about the polypill. It came from the Freedom trial. It was quite amazing, you know, because patients with coronary disease and diabetes, only 20% were taking care of the disease in itself, the diabetes and the risk factors and so forth. And things have to change. So I think now is the time that maybe this epidemic of obesity and so forth may be addressed by these discussions, which is a new culture, isn't it? Well, anyway, thank you very much. This was an interesting study. And then we have two studies on atrial fibrillation. Actually, very interesting studies. Let's see. The first one is the ARTESIA study. Basically, the title is Apixaban for stroke prevention in subclinical atrial fibrillation. This was presented by Dr. Healy from the McMaster University in Canada. And it's very interesting. I don't know if you're in agreement, but it seems to me that atrial fibrillation in a silent way is quite prevalent in this world. We learn when somebody gets palpitations, but subclinically, when you put pacemakers and so forth, you see a lot of people with atrial fibrillation. But here's the question. If you have silent atrial fibrillation that you detect because whatever, a Holter monitoring, are you going to start giving antithrombotic agents? I face this all the time. And the question is, what is the incidence of thromboembolism when you have something so subtle, and the incidence of bleeding when you give apixaban, for example? So I think that this study is quite interesting because it addresses this issue in people with subclinical atrial fibrillation. And the question is, if you give apixaban, there's enough thromboembolism to give the drug because you are really buying for bleeding too. So this is basically the aspects of the study that we are going to present. The ARTESIA trial. This was designed to determine whether apixaban would result in a lower risk of a stroke or systemic embolism than aspirin, with an acceptably low risk of MACC bleeding among patients with risk factors for a stroke who also had subclinical atrial fibrillation detected by a pacemaker, defibrillator, or implantable cardiac monitoring. Well, let's go into the detail of the study because it's interesting. Well, first of all, when you go to the literature, the incidence of atrial fibrillation in people at high risk with thromboembolism is about 1% per year. So the thromboembolic phenomena is less than in patients with symptomatic atrial fibrillation. So let's go now into the details. This trial involved patients with subclinical atrial fibrillation defined lasting 6 minutes to 24 hours. They were randomly assigned in a double-blind, double-dummy design to receive apixaban at a dose of 5 milligrams twice daily, or then aspirin, as I mentioned before, at a dose of 81 milligrams. Now, the number of patients included in the study were over 4,000, and the follow-up was 3.5 years. Mean age, 76 years, and the CHATS-BASC score was at an average of 3.9, so reasonably high. Well, the primary efficacy endpoint was a stroke or systemic embolism, and this was assessed by intention to treat. And the primary safety outcome was MACC bleeding. Look, let's see the results. Now, first of all, after a mean follow-up, as I mentioned, of 3.5 years, a stroke or systemic embolism occurred in 0.78 per patient year in the group with apixaban versus 1.2% in the patients treated with aspirin. This was a good p-value, but then you go into the bleeding and it happens the opposite. The rate of MACC bleeding was 1.71% in the apixaban group and 0.9% in the aspirin group. So it's interesting because when you summate all the outcomes, bleeding plus thromboembolism, the group treated with apixaban does a little bit worse than the group treated with placebo. But it's better in systemic thromboembolism, which may give you a residual neurological process where bleeding is not. But this is a very interesting study, and I read just the conclusions as they came up from the New England Journal of Medicine, and I quote, among patients with subclinical atrial fibrillation, apixaban resulted in a lower risk of a stroke or systemic embolism than aspirin, but at a higher rate of MACC bleeding. What are you going to do with the next patient? You're the head of pacemakers there at the Cleveland Clinic. You have put a patient who has a pacemaker for A, B, C, or D reasons, and you see atrial fibrillation for 12 minutes. I ask you what you're going to do?
I think it will be hard to apply this to clinical practice. I think this was a study that needed to be done. But if you look at the absolute numbers, there was a 0.8% absolute increase in bleeding and a 0.4% reduction in stroke. So I think you have to individualize per individual patient. So patients that have a fairly high risk of stroke based on the CHADS VASC and relatively low risk of bleeding estimated, maybe I will go for it, versus the frail patient that may have higher competing bleeding risk, I may not go for it. A few questions about the study that I'm still. We know 6 minutes of atrial fibrillation, but if a patient has 6 minutes and nothing else for a year, is that the same patient of a patient that has 6 minutes continuously every day of atrial fibrillation? Or what to do with patients that have between 30 seconds and 6 minutes, maybe repeated episodes, paroxysm every day? So still there is a lot of work to do, I think, to understand what the best strategy is for these patients. I think for now, I'll continue to individualize, but it's good to have some data that show some benefit of doing oral anticoagulation in patients with subclinical atrial fibrillation.
Well, thank you very much. Amanda, you have a patient, as you see every day, with heart failure, and you are monitoring, and you see the atrial fibrillation there coming. What Pasquale is saying is we need judgment. Is this correct? Because in this situation, it's very difficult.
I think so. And I was just thinking through, well, what are those higher risk features? What patient populations might I be more likely to want to anticoagulate? The one that particularly came to mind for me is our patients with amyloidosis, where we do see subclinical atrial fibrillation, and we know they have a fairly high event rate related to that. We also know that even sometimes if they don't have atrial fibrillation, there can be smoke or spontaneous echo contrast on the echocardiogram. So I think I'd be particularly looking for those high risk groups.
Thank you. Joshua, the next guidelines, are you going to put atrial fibrillation subclinical? It's not now.
Well, as you know, I can't say what's going to be in the guideline before the guideline comes out. That's still a little bit in the wrestling phase. I do think there will be conversation about it because it's become something that's more prominent in common conversation. The guidelines, as you know, are, I would say, the last actor in recommendations. We want the most solid of evidence before we will take a stab and tell people to or not to do something. But I'm sure that it will be discussed.
So, Roxana, what do you think about the subject? It's an interesting one, isn't it?
I think
it's very frequent.
I think it's tremendously important because so many of our patients now have devices that detect atrial fibrillation and subclinical atrial fibrillation, and also atrial fibrillation is rather undertreated in our country for sure, and I think kind of seeing these kind of data is very, very important. The balance of ischemic and bleeding events continue to be a dilemma, and I think your next study hopefully tries to address this issue. But the idea that there are important reductions in catastrophic events like a stroke, which no one wants to have, is a very, very important one to consider. So this will have some important impact at some point.
It's an interesting subject, isn't it? But a lot of judgment, apparently. Yeah. Well, this is the first paper on atrial fibrillation. There is a second paper on atrial fibrillation, the AZALEA-TIMI 71 trial, which is about factor 11, which neutralizing it, it seems something very interesting. You may prevent thromboembolism, but you also prevent bleeding. Or you not...
The Holy Grail.
Exactly, so it's a pleasure. Abelacimab, did I say this properly, Roxana? Abelacimab.
Abelacimab.
Abelacimab. It's not how it's written, Roxana.
It's abelacimab.
Okay, I'm just saying.
Abelacimab. Abelacimab.
Okay, okay, good. This is a very interesting study, actually, and I like to, you know the background. DOAC or NOACs appear to be better than vitamin K antagonists in terms of thromboembolism, and even in case of bleeding. But still there is bleeding there when we give these drugs in patients with atrial fibrillation. So then we have this interesting factor 11 inhibitors, abelacimab, I'm sorry for if I don't pronounce properly, which is an interesting one that is evolving very rapidly, and the field is evolving very rapidly and interestingly. So I would like to say that This study, to me, is an important one because it has outcomes, and is to evaluate the bleeding profile of abelacimab relative to rivaroxaban in patients with atrial fibrillation at moderate to high risk of a stroke. So, what kind of patients enter into the study? These were patients over age of 55 years with any history of atrial fibrillation or atrial flutter with planned indefinite anticoagulation. In the majority of patients, the CHA2DS2-VASc was high, was 4 or higher than 4. Now, the number of patients that actually entered into the study were over 1,200. They were randomized at 95 sites in 7 countries between March of 2021 and December of 2022. So actually, it's all very recent data, very exciting. I said 1,200 patients, atrial fibrillation of moderate to high risk of ischemic stroke, as we mentioned by the charts of over 3. The patients were randomized in 2 different dosages of abelacimab, 150 milligrams subcutaneously monthly or 90 milligrams subcutaneously monthly. And the other group of patients were treated, the third group, I would say, with rivaroxaban orally, 20 milligrams daily. The primary endpoint, measure of clinically relevant non-measure bleeding. So, let's go into the results. Well, here we have an interesting data safety monitoring committee unanimously agreed to recommend termination of the trial because of the substantially greater than anticipated reduction in measured and clinical relevant non-measured bleeds in the abelacimab arms compared to the rivaroxaban arm, and a benefit risk very favorable for the drug. Fascinating. Well, what is the data? And it's interesting. I will tell you exactly what happened here. So, at 360 days, using this approach monthly, was 8% of measured or clinically important bleeding in the group treated with rivaroxaban, and in the other 2 groups treated with this new agent, inhibiting factor 10, 2 to 3%. This is at 360 days. Where then at 730 days, 15% bleeding events in the rivaroxaban group versus 4 to 5% in the group treated with abelacimab. This is very exciting. I mean, it's amazing, isn't it? But let me continue. What about thromboembolism? Look, practically was the same, 1% for all the groups. What about safety? The same. So here's the summary of abelacimab. Substantial reduction in bleeding compared with rivaroxaban, 70% of decrease in measured or clinically relevant non-measured bleeding, with 74% of measured bleeding, 93% of measured GI bleeding. GI was important. And the drug is very well tolerated. So now the next trial, phase 3 trial, is going to be in people unsuitable for anticoagulation. But anyway, so what do you think? What do you take from this? It's an important study. Let me ask Roxana first, because she's very much in this anticoagulant business. Tell me.
Well,
are you excited?
I'm very, very excited. As you know, the Factor 11 programs, this one is an antibody. There are 2 other small molecule programs, all in phase 3 for outcome studies that will be evaluated. But to me, this is a very, very important breakthrough in terms of preserving the thromboembolic benefit of a drug without increasing bleeding. That has just never been seen before. Every time we give drugs that reduce thrombosis or thromboembolic events, we're increasing bleeding. And that has always been an issue for so many of our frail, more complex patients. uncoupling hemostasis and thrombosis is just a tremendous way, and going upstream to factor 11 is brilliant. What I was very, very excited to see is this tremendous reduction with 95% abolition of factor 11, which they showed. But most importantly was the fact the safety. These patients needed surgeries, Dr. Fuster. Yeah, they went through surgeries. There was no excess bleeding. This is a tremendous breakthrough.
So, Pasquale, it's not interesting. I remember medical school, factor 11 was there, but we didn't pay much attention. So this is a factor very important in thrombosis, but it doesn't play a role on the bleeding when you neutralize it. It's not exciting?
It is very exciting indeed. And really, this is a group of patients where, for example, GI bleeding, the signal that we saw there was an issue with the entire class of DOACs across the board, and that was significantly reduced by this drug. I would have loved to finish the study rather than stopping it early, just to have a better sense of whether the thromboembolic protection was really preserved. But now we have an ongoing study to look at that, so that's still exciting though.
Joshua, what is your degree of excitement?
Well, during my day job, I practice medicine and I take care of patients, and I would say 2 to 3 times every single day, I am asked whether or not I can stop the anticoagulant for someone to have a colonoscopy. From that, if this drug moves forward, I don't think that's going to be an issue anymore. I think practically speaking, every patient is afraid of bleeding, and if I can tell them the bleeding rates are extraordinarily rare and commonly not to worry about and shouldn't affect their life, I'm really eager to see the outcomes of a phase 3 trial so I can be reassuring and make it easier to extend these therapies to even more of the patients. I actually like injectables. I think they're taken more reliably than daily pills because people make a special calendar appointment rather than trying to remember as they're getting ready in the morning or getting ready to go to bed.
This is interesting also for adherence, isn't it? Subcutaneous injection monthly, isn't it, Amanda?
Yes, and I think the interesting thing is it's a theme that runs through the trials you've selected today. We just heard about the weekly semaglutide injections that we've become familiar with. Here we have a monthly injection, and then we're going to even move on to some studies where you're dosing them maybe only once or very infrequently during the lifetime. And I think that really changes the approach for patients. I think for some patients that'll work very well. For others, may be more challenging, and the adherence piece that comes with this may have to be rethought on our end as healthcare providers.
I think there is a change in medicine that is becoming very, very important. You know, we all know that adherence to medications is a huge problem, and this is why we were very involved in a polypill. Yeah. But the reality is that, and we are going to see in a few minutes more studies, that this kind of injection subcutaneously once in a while may be the answer to the problem of adherence, isn't it?
Well, yes and no. The devil's in the details, right? So we need more safety data. And of course, these phase 3 programs will tell us. Also, the half-life of this drug is almost 30 days. And so with this small group of patients, 1,200, albeit, we still need much more data. The small molecules that are asundexian and milvexian will take on over 50,000 patients. So we're going to see a lot more. And there's a lot more to learn about this, but I'm very excited.
Exciting, isn't it? Yeah. Okay, now we are getting into something that I'm still thinking for the last 3 years about this, is the ORBITA trial. You remember the development of this trial. Let's go into the details. Well, the original ORBITA trial, if I remember, was a trial in the UK where patients had angina. Many patients, I think, had one vessel disease, actually. It was not very severe angina. And the patients were randomized into PCI versus anti-anginal medication. And what they measured was a treadmill testing, and they found there is no difference. And he said, well, maybe there's no difference because angina, you know, is treated well with anti-anginal medicines and PCI. Anyway, I was not so turned on. There was a lot of discussion. You remember pros and cons and all of that. We should not use PCI. We have now, and well, anyway, now they came with the second trial, which is called ORBITA 2. And it's very interesting. What they did is no medicines, not anti-anginal medicines, in patients with a stable angina. And then the others will do PCI. And there were questions in the original trial, the placebo effect of being in the control group and so forth. So I think it's quite fascinating. We have a trial here in which you are randomized with a stable angina into PCI versus no drugs, but you go to the cardiac cath lab, you have an angiogram, and you're anesthetized, and you don't know later on if you had PCI or not. So it's a very interesting blind study. So in that regard, it's amazing what they have done. Well, anyway, let me go into the details of this. This was a double-blind, randomized, placebo-controlled trial that was conducted at 14 sites in the United Kingdom. The details are the following. Double-blind, randomized, placebo-controlled trial of PCI in patients with a stable angina. Stopped all anti-anginal medications and underwent a 2-week symptom assessment phase before randomization. And the randomization was 1-to-1 ratio to undergo PCI or placebo. And then these patients were followed for 12 weeks, all had angiography. So a total of 301 patients underwent randomization, as I mentioned, to the PCI group or the placebo group, and the average age was 64 years, 79% were men. Now, the question, how they measure this, the primary endpoint, actually it was an angina symptom score, which was calculated daily on the basis of the number of anginal episodes that occur in a given day. They also looked to events and so forth, but the important thing was actually the angina. Here are the results. At 12 weeks of follow-up, the mean anginal symptom score was 2.9 in the PCI group, and in the other group was actually 5.6 in the placebo group. So the results were very significant in terms of PCI being better than no treatment, no anti-anginal treatment in patients with a stable angina. And these are the conclusions as they were presented in the New England Journal yesterday. Among patients with a stable angina who were receiving little or not anti-anginal medication and had objective evidence of ischemia, PCI resulted in a lower angina symptom score than a placebo procedure, indicating a better health status with respect to angina. Now, Joshua, I have two paradoxical thinkings here. First of all, I think the results are obvious, should be obvious. I mean, we do PCI, and the angina goes. In somebody who has angina, you don't treat the angina. We see this every day. So the question is, why the study? Now comes the other side. And then the study is the most sophisticated approach I have ever seen in a study in the blind fashion. So tell me, you understand it? So there is something that doesn't click to me yet.
So there were several things about this study which I found amazing, like you. First, the sham approach in an interventional study is an incredible thing to do and gives us as clear evidence as we could have. Second, it's very nice to know that what I think about on a daily basis is actually true, so that reestablishing good blood flow in the setting of exertion relieves angina. I was interested to see that it did not abolish angina, which suggests to me that there's a variety of mechanisms of chest pain, some of which are facilitated by occlusive disease in conduit arteries, but there must be also other components like microvascular disease, a field that I think is exploding now as well. And I was also amazed to see that the value of angioplasty was similar to a good anti-anginal drug. What I really think this allows us to do now is to have an educated conversation with our patients in the office and see which approach they may prefer as the first or second step in trying to make them feel better.
Thank you. So, Pasquale, what do you think about?
I think it was an interesting design because of they call it placebo procedure because sham is too negative, I guess, to call it. But definitely now we have an answer that PCI works as an anti-anginal agent, something that we knew from observational studies already just by looking at patients and sending them to the cath lab. The question about what to do first, anti-anginals versus PCI in a given patient, I think is still open to me. It's not clear based on the Orbita 1 and 2 what to go for first for individual patients.
Roxana, as fantastic is the design of this study, and I agree with you, is this going to change your practice? In other words, what did you learn of this study that you are going now to apply?
Well, I've always known that PCI improves angina. I think what we didn't know is how much of the PCI procedure has a placebo effect on patients. And Orbita 1 on patients on multiple anti-anginal meds showed that its incremental benefit in reducing angina and improving exercise time was not there in 200 patients. And it brought to the question of many naysayers that PCI is useless in chronic coronary syndromes. And I think that was one of the things that we as interventionalists were grappling with and had to basically explain ourselves and why we're doing PCI in these patients. Orbita 2 tells us that angina frequency can be significantly reduced in patients who receive a PCI. And I think, Josh, you're 100% correct that maybe Orbita 3 is going to look at microvascular disease as well. And I think this was an unfortunate fact that we need to show this, but for all of us to understand that these procedures, interventional, injectables, and medications have a placebo effect that we need to take into consideration when we're looking at effect sizes in these randomized placebo-controlled studies.
Thank you, Amanda. What did you learn?
Well, again, I think it's a confidence in our shared decision-making with the patients that we really know what we're offering there. And I do think it's interesting when PCI has been around for so long that almost for me, the sequence of trials here is sort of back to front. Usually you would have the trial against no medication therapy, and then people would come back and say, oh, the medicines weren't enough, that wasn't a fair comparison, and then the medicines get optimized as they were in Orbita 1. So just an interesting sequence of events.
Well, Joshua, I will tell you what I learned is, first about the methodology, I thought was fantastic, as you mentioned, intervention. But the second is we are beginning to talk about quality of life. You know, all of our obsession with this disease, coronary artery disease, has been outcomes, outcomes, outcomes. And you know, you have the patient in front of you, and the problem is the angina that the patient has. So I think it's very important we begin to talk about quality of life. And this is certain in terms of quality of life is a perfect study. As you mentioned, how much angina, this microvascular disease there. So it's a very complex issue, but at least to me, is the beginning to start thinking very much on the quality of life here. Well, now we have 3 studies that to me are fascinating and are changing the field, certainly on the genetic aspects of cardiovascular disease. And let me begin with the first one, Lepodisiran, which is a trial that was presented by Stephen Nissen from the Cleveland Clinic. And this is how you counteract lipoprotein A. Well, we all know the story of lipoprotein A. It appears to be more important than we thought in the past in terms of cardiovascular disease. But what can we do today? I was excited about 3-4 years ago that maybe drugs that interfere with the lipid process may also interfere with Lp(a). It has not been the case with the PCSK9. Really, you don't do anything. I said this in a number of my patients and didn't work. So there are new drugs now that are actually targeted to this genetic RNA kind of pathway, and this is one of them. So let me describe the study. The trial was conducted at 5 clinical research sites located within the United States and Singapore between November of 2020 and December of 2021. So we are talking about 48 adults, not a large number, with a high Lp(a) without cardiovascular disease, and the concentration of Lp(a) actually is more than or equal or more than 30 milligrams DL or 75 millimolars per liter. So I consider a high LP-little-A much higher than these levels, but at least you may consider these abnormal levels. These participants were randomized to receive placebo or a single dose of the drug, Lepodisiran, about 4 milligrams, and they go into 5 different dosages from 4 milligrams to 608 milligrams subcutaneously. And then the question here was the primary endpoint. And the primary endpoint is outcomes was safety and tolerability. But they also look at the plasma levels, of course, of the LP-little-A, which to me is quite important. Well, at least to the judgment of the study. So in terms of safetiness, there was only a serious adverse event that took place, and they don't give much importance. The plasma concentration of Lepodisiran reached peak at 10 hours and then goes down. So basically the drug gets into the liver and begins to do the work with very interesting results long term. That's the story. Now, the question is what happens with LP-little-A? And what happens with LP-little-A is quite interesting. It depends on the dose, but just to make the long story short, at the lowest dose of this subcutaneous approach is actually with a single injection is a 41% decrease in LP-little-A with the low dose, and with the high dose is 98%. So the results are quite significant in terms of decreasing LP-little-A, and it appears to be a safety drug, a single injection, and then they look this for a long period of time. So in this phase 1 study, I read the conclusions. It appeared in JAMA. In the phase 1 study of 48 participants with elevated lipoprotein A levels, Lepodisiran was well tolerated and produced dose-dependent long-duration reduction in serum lipoprotein A concentration. The findings support further study with this agent. There are other 2 agents that have, as you know, that have been tried with this approach. Joshua, what do you think about LP-little-A? It seems we are getting closer and closer, isn't it?
I think so. I think these trials will be helpful in two regards. One, agents to be able to reduce this LP-little-A down to levels that are not thought to be pathogenic, and also to establish actually that elevated levels of LP-little-A are important. I think I do not remember a time where we are moving both with the medication and to determine if this is a problem at the same time, maybe HDL a while back. But the results of the study will not just be drugs work, but the results of the study will be LP-little-A is bad. And I believe that that's the case, but it's been really hard to establish that independently until now.
What you are saying, you're clever on this because the story of HDL was important. You can put HDL in the sky, but the number of events don't change. So here we have LP-little-A going down, and we don't know about the events. What do you think about LP-little-A and what is happening?
I think it's interesting because as far as I understand, there is nothing we can do to lower it. Exercise doesn't work, statin don't work. So I think for now we have something that seems to work extremely effectively. So it's exciting in that sense.
Roxana?
Oh, I think this is a very, very important arena, genetic sort of modification to try to see how we could reduce a very important atherogenic molecule like LP-little-A. We learned about it from Peter Harpel at Mount Sinai. Yeah. He was telling us about that all those years ago. And as a fellow, I remember looking at plaques,
20 years ago.
Plaques that had LP-little-A and macrophages in atherectomy specimens. This is an important, I don't let a patient's lipid profile has to include an LP-little-A. At the very least, the very first time, the patients absolutely have to know their LP-little-A. I believe it's incredibly important. Josh, your point is so crucial for this hour.
I agree with this, Amanda. Lp(a) is very tricky, particularly when you have a younger person and so forth, and you see more and more as you look for. Is not correct?
I think so, yeah, as awareness goes up. But it is a difficult situation to put clinicians in, to be checking for something and then not really knowing what to do with it. Of course, here what we have to wait for, as mentioned, are the outcome studies to know, does this really work? Do we really see a reduction in atherosclerotic burden and a reduction in hard endpoints? But this is certainly a big first step along the way.
Okay, so let's see what happens. Certainly, there are, that I know now, there are 3 different drugs that are being really addressing the issue of the origins of Lp(a), and I think this is quite interesting. Well, this is the beginning of something else here. We have a study, the HEART-1 study, safety and pharmacodynamic effects of VERVE-101. What is that? Well, we are talking about patients with heterozygous familial hypercholesterolemia, an inherited disease, and certainly to reach the normal levels of LDL in these patients is not easy. So let's see what happened. This is the by the way, this is the study that I remember presented in a trial like here, that only 10 patients are part of the study. So it's interesting, but certainly it's very fascinating. So let's go and see what this is all about. There is data, as you know, about editing, and that is, we talk about RNA, but now we are talking about, you go to the gene, and the gene PCSK9 is bad for you, because basically it prevents the cholesterol to get into the liver. So the question is, can you modify that gene, what's called gene editing? And this is a very unique study that you go directly to that in PCSK9. So you inactivate the very origin process of what we are talking about. Well, this data in primates, non-human primates, with the data is interesting, and that is a single infusion of this VERVE-101. At 2.5 years, you have a significant decrease of 80% of the PGLT2. It's amazing. It's an amazing kind of aspect. Well, here we have 10 participants. This is the first, the HEART-1 is the first in human phase 1b trial designed to evaluate the safety and tolerability of VERVE-101. We are talking, as I mentioned, 10 participant treated patients across 4 dose cohorts. Well, 0.1 milligram per kilogram in 3 patients, 0.3 milligrams per kilogram in 3, 0.45 milligrams per kilogram in 3, and 0.6 milligrams per kilogram in 1. So these are the 10 patients. This was delivered as a single infusion via a peripheral intravenous approach. The patients were 18 to 75 years of age, heterozygous familial hypercholesterolemia. They had established atherosclerotic cardiovascular disease. They had uncontrolled hypercholesterolemia. The primary endpoint, safety and tolerability. And then you had, what about the blood levels of PCSK9 and of LDL cholesterol? This was quantified. And the study was a study of about 1 year with a single injection. So let's see what happened with PCSK9. Well, basically, at the highest dosages, the decrease in PCSK9 at 1 year actually was 59 to 84%. So in this context, very good data, very interesting. LDL cholesterol, 48% to 55% decrease. And this was extended over 180 days. So single injection forever. Very interesting. Like the other studies, once you get into the liver and you block these original pathways, it seems you can sleep quietly. Although you mentioned something important is about the side effects. We have to learn a lot about these long-term studies. Well, there is one issue here, and I don't know the answer. There were 2 cardiovascular events in 2 participants which were not easy to swallow. One was a fatal cardiac arrest about 5 weeks after the infusion, and the other was a myocardial infarction and non-sustained ventricular tachycardia. So the safety monitoring committee said this has nothing to do with the drug, or probably is not related to the drug, and is related to the underlying disease. From 10 patients, 2 having these problems, you don't sleep quietly. So they tried to dismiss this, and they certainly end up with conclusions that are interesting. First, dose-dependent reductions in blood PCSK9 protein and LDL cholesterol levels following the infusion of VERVE-101. The LDL cholesterol reductions, 48% to 55% in the 2 highest dose cohorts. Durability, 6 months to a year. Safety profile supports continued development of the drug. That's the only issue here. So finally, in patients who require deep LDL cholesterol lowering over decades, single-course gene editing medicines may emerge as an option to overcome limitations of the chronic care model. So Roxana, what do you think?
Well, I mean, I think it's fascinating, gene editing and changing the entire process, especially if you can start early. These patients with familial hypercholesterolemia really develop very early atherosclerosis, and to be able to do this with a single injection is very, very promising. But I think the safety is is crucial. This has to be safe as well as effective. And so as a phase 1 trial, I think it's a huge win to be able to show this, but more to come.
Amanda?
Yeah, I think certainly more to come. Putting myself in the position of the patient at the moment, taking, a single therapy, but something that's very permanent and with you long term, and we don't know what those long term effects could be, versus the PCSK9 inhibitor, maybe a monthly injection. We do have a good treatment here. So I think it's very exciting. I think we're all watching this space. I'm very interested that some of the myocardial disorders as well, hypertrophic cardiomyopathy, inherited TTR amyloidosis, are starting to go in this direction as well. And we certainly watch the science as it evolves.
Yeah, thank you. Pasquale?
Yeah, I think here the key is the safety. Since it's a once and done, you cannot undo it once it's done. So that's why I want to make sure that really safety is there, but it's very promising as a phase 1, yeah.
So as cardiologists, we now have to start talking about the liver, isn't it? Because really the pharmacology is moving in a direction which is quite interesting. And I still remember, in your training, you all talk about cardiovascular diseases. Now we are finding the brain is critical. All the risk factors are making the brain cognitive function to be affected, and now we are getting into the liver. So it's fascinating. So give us your word about this particular study.
So I think the appeal of a one and done is really high. I also think the requirements for proof of safety are equally high, and that the inability to reverse what's been done will always give me pause until there's been a pretty clear demonstration of safety in more than 10 patients.
Okay. Well, thank you. Quite intriguing and interesting. And this is the last paper, which to me was a real surprise. Why was a surprise? Because blood pressure, sure there are genetic aspects of blood pressure, but when you talk about most of the people with hypertension, we don't know the cause. Mm-hmm. Well, anyway, they can now get into the genetics, and this is the so-called Cardio-1 study. Fascinating. It's in patients with hypertension. And the question is, where are you going in terms of the genetics of hypertension? Well, they start talking, of course, that this is an epidemic. I mean, 75% of the people who have hypertension they are not treated properly. And half of the world is hypertensive and they don't know. So we are really dealing, and actually is the single number 1 cause of cardiovascular mortality. Well, Lepodisiran, whatever. Look, this apparently appears to be a miracle drug. This was investigated interfering with the RNA subcutaneously, but the RNA of what? Of angiotensinogen. Mm-hmm. So angiotensin is probably important in the number of cases of hypertension, the so-called idiopathic or unknown kind of hypertension. Well, they went after this RNA, and actually the results, frankly, are fascinating. Let me define the study. These were patients 18 years to 75 years of age, mean systolic blood pressure between 135 and 160 millimeters of mercury by ambulatory blood pressure measuring. Basically, they had 5 different groups with 5 different dosages, 4 different groups using this drug, Lepodisiran, and versus placebo. And the primary endpoint was change from baseline to at month 3 in 24-hour mean ambulatory pressure. They measured actually at 3 months after using this drug and at 6 months. And the safety endpoint was also being looked at. Well, I find this very fascinating. First of all, what happens with this angiotensin precursor? It decreases by 95%. But with a single use of this drug, actually, this decrease lasts for a long time, like the other pharmacological agents that address the liver with the RNA. So this is a given. The question is the results. The results were interesting. Basically, at 6 months after having given the drug, there is a decrease in blood pressure by 12 millimeters of mercury in the higher dose. And in terms of side effects, very safe, very favorable safety profile. Here the question is, they can go to higher dose. Nothing happened in terms of safetiness. And this drug, certainly, it may be possible to be added to other antihypertensive medications if this is necessary. The drug is given subcutaneously every 6 months. So just one single dose for the treatment of hypertension, which is so poorly treated. I think this is fascinating. And Pasquale, what do you think?
Yes, I mean, compliance for these patients is an issue. And if you have something that works like that every 6 months, it's truly amazing. Yeah. So I have nothing else to say about that.
It's unbelievable,
yes,
isn't it,
yeah.
Amanda?
Yeah, I agree. I think the scalability and the cost considerations, though, we do have to keep in mind. How much would this really replace our incredibly important public health measures of getting out there and treating people's high blood pressures? I'm not sure how scalable it would be. Although, of course, my head as a heart failure cardiologist starts to go towards, well, we're getting into the RAS system here. Would there be anything that could be translatable into the HFrEF patient as well, perhaps?
So, Joshua, we are treating the heart going to the liver. This is what we are discussing this morning.
I actually find these results incredibly encouraging. We have been, I would say, as a community, doing a mediocre job at treating hypertension for a long time. This is another new approach to that problem. We have the interventional approaches that were just approved by the FDA. I think the more approaches we can bring to bear, the better we're going to do by offering patients things that may comport better with their desires and ability to be compliant with.
Roxana?
Well, I'm also fascinated by this. Another 6-month drug, inclisiran, is also every 6 months for PCSK9 inhibition. Very, very interesting. The devil is in the detail. I want more data. And because I remember how excited I was about renal denervation early on.
Sure.
And then we had placebo procedures and found that there was a placebo effect actually in those. And so therefore, I think we need to just hold our breaths and remember, sometimes you need your blood pressure, right? So you really don't want to make the frail elderly patient too hypotensive and in a 6-month period. Yeah. So there are a lot of things that we have to consider, and then cost as well. But I'm very excited, of course.
Well, it's interesting, an interesting meeting, isn't it, from the scientific point of view. We have a number of interesting trials and studies, and maybe what I'm going to ask you, each of you, is which one of the studies presented today here you are most interested, excited, and so forth. Amanda?
Well, for me, it has to be the SELECT study. I think the more we're learning about the benefits of addressing our patients' metabolic health, whether that be by treating obesity per se or treating the milieu of metabolic abnormalities that cluster together, that's really exciting for long-term cardiovascular health for me.
Excellent. A nutritionist.
Yes. For me, it was Orbita 2. I was most impressed by the methods of this trial, and I think they have raised the standard that will be necessary for interventional trials going forward.
Very interesting. You, Roxana.
Well, just to be different,
Factor
SELECT
11.
and yeah, of course, because SELECT was great, Orbita amazing, very important, but Factor 11. Can you imagine that you can reduce thrombosis without increasing bleeding events? I just can't even imagine it. And so the possibilities are tremendous. Going into an operation, we're asked, stop, don't stop, procedures. I mean, it really is very, very important.
Pasquale?
I have to go with SELECT. I think it's a groundbreaking trial, and it will change the healthcare in the US at least, I think.
I expected you were going to get into atrial fibrillation.
Well, but that was quite impressive.
Number two.
Yeah. Number two. And
Good
number two is
contender.
Factor 11 inhibition, of course.
Yeah. Thank you. Well, to me, the most exciting thing were you. I have to say, this has been wonderful. Very interesting discussion about fewer studies. All of you have a very excellent points of view. In fact, I didn't hear an answer to any question that I would question the answer. And I think this is very unusual. We usually have a lot of discussions, different points of view, and sometimes some controversies. But I'm very happy with this hour that we had with you, with these AHA scientific sessions. I hope you enjoy it, and thank you very much for being with us today. Thank you. Thank you, the four of you, too.
Thank you.
Thank you.